On our morning show today, we have a chance to introduce you to a new member of the community and a new service at the Richland Hospital. Dr. Douglas Bull is here and is going to talk about what the hospital has to offer and ophthalmology. We're going to learn about that a little bit here today as well. So good to have you in the studio. Welcome.
Thank you. Thank you for having me.
Great to have you. So give us a little bit of the background. Tell us a little bit about yourself, if you would.
Again, my name is Douglas Bull. I've been a practicing ophthalmologist for the past will be 27 years, and started my ophthalmology residency in 1996, and been this will be my third different practice that I've been at. Primarily practiced in Illinois for the past 25 years, and we joined Reedsburg Area Medical Center a couple years ago. My family and I moved up here, and have really enjoyed the community, and looking forward to expanding our services to Richland Center Hospital.
So what made you want to pursue not only medicine, but this form?
Ophthalmology was interesting to me. I started initially in medical school. I thought I would be an orthopedic surgeon, but I was in the United States Navy. They were kind enough to support me through medical school. So I did a general surgery internship, and then at that point you have to go out into the fleet. So I became a U.S. Navy flight surgeon, and that was very interesting. In that capacity, though, you do a lot of eye and hearing prevention protocols that you have to engage in to keep the crew and all the sailors healthy and happy, and being able to do their jobs proficiently. So kind of got interested in ophthalmology at that point, and pursued it after that.
And you found up in Wisconsin after growing up in Illinois then?
Correct. Yeah. Central Illinois is where I grew up, in Springfield, and went to school in Champaign at University of Illinois. And my undergrad was there, 2 years of grad school, and then my first year of med school. And then at Illinois, you either stay there or go to some separate campuses. And so I was in Rockford, which not too far away.
No.
And still have family there as well. And after that is when I went to actually went to San Diego for my first year of after medical school, and then did the whole Navy thing. Was stationed in Pensacola and Jacksonville, Florida, and then after that I was no longer active duty, so I went into my residency, and that was in upstate New York in Syracuse. So I'm used to the snow. So, but 3 years there, and then my first practice was in a rural community in Illinois, Macomb, Illinois, about the same size as Reedsburg, about 10,000 people. They have a university there as well. The state of Illinois does, and then moved back to Champaign, where I went to undergrad, which was great. We were just looking for a change of pace. All our kids were grown up, and so my wife and I wanted a smaller place again with more community ties, and being involved in the community, and providing still a high level of eye care for the community, and in many cases so that it's more it's a closer to home experience, and not have to travel hours upon end to go to places, to get essentially basic services a lot of times. So
what attracted you to Richland Center and the Richland Hospital? This
again, it was similar to Reedsburg. I think there was a lot of need, and have had some patients come up to Reedsburg from there, and it's a lovely drive down here. So it's enjoyed coming down here and expand our services to the Richland Center Hospital as well.
And this is something new for the Richland Hospital, so I'm guessing you're excited to be kind of on the ground floor then.
Yeah, we're building it from scratch, essentially. I think there were some services here. It's been a while. I'm quite certain, at least 5 years or so from what I understand, but being able to come back and bring some services such as cataract surgery and things like that back to the community locally, and that's really a great thing.
So that was my next question. What do you do? I mean, could you describe your services?
So as an ophthalmologist, I'm a medical doctor, and so I do provide basic services like just Eye exams. I don't do contact lenses, but other than that, eye exams. But mostly treating medical diseases such as glaucoma, cataract, and macular degeneration, dry eyes, variety of common conditions like that, and then also the surgical conditions. In my specific training, I particularly like performing cataract surgery and eyelid surgery, so variety of things like that, but primarily cataract surgery, which is a very common thing that most people after 60 to 70 typically need. So
When you're practicing here in Richland Center, then you're going to be doing some surgery,
yes.
some cataract surgery, so people
Correct.
don't have to drive to Madison or La Crosse or wherever.
Correct.
In
Yeah.
other words. So
Yep.
that'll work out really well. Why are routine eye exams important? I think we talk about that. How often should we have our eyes examined?
After age 60, our Academy of Ophthalmology recommends once a year, and that's primarily checking for glaucoma. It's a very common condition after age 60. In many people, your risk goes up just as a function of age. Glaucoma is just a progressive damage to the nerve cells in the back of the eye, and consequently that can cause permanent damage. It's kind of the opposite of macular degeneration, where you tend to lose your central vision first, but glaucoma, you lose peripheral vision. So many people aren't aware of that until they've had quite a bit of loss. And what's preventative eye care is that we're checking the eye pressure, which is a risk factor for that, but it's not the causative factor for glaucoma. And then also examining the back of the eye and performing specific testing that can help us to diagnose that as well.
Are there some ways that we can ward off those things, or is it just inevitable that you're going to have it if it's in
It doesn't mean everybody's going to have it. Just like family history is a higher incidence. Yeah. But the best thing is, catching diagnostic testing and catching it early is the key, because then we can use topical medications, laser, surgery in more advanced cases to prevent further vision loss. So, everyone doesn't get it, but it's something to be examined for. Also, during those preventative exams, oftentimes we'll come across, cataracts obviously might have early macular degeneration. We're also doing exams for people that have diabetes. We need to look at their eyes at least once a year. If there's active bleeding or other problems in the back of their eyes, then we'll we'll be examining them more frequently.
Could you talk about cataract surgery? How cataracts are treated, basically?
Well, cataracts, we remove the cataract with something called phacoemulsification. So phaco just means sound. Emulsify is the same as if you're emulsifying during making a vinaigrette or something like that. I'm not the most expert cook, so but it may not be the greatest analogy. But basically, it's dissolving the cataract with ultrasonic energy into little tiny pieces, and then those go out in a slurry or a solution essentially, and then we replace that material with an implant. So in many cases that is able to number one, we're restoring someone's vision usually, and secondly, we can also typically get rid of distance and or near correction, so you don't need glasses or I would say most people opt most of the time to at least have appropriate distance correction or distance vision and not have glasses for that, and then just have a pair of readers to wear. But there are other options of implants that you can use to correct for near as well. Additionally, people have astigmatism that many people wear glasses for. That can easily be corrected with the implant technology that we have now as well, because it's designed such that it'll reduce or eliminate the astigmatism, which is important as a component of the distance acuity, distance vision.
Could you talk about lenses and what type of implants are available?
I typically use what's pretty standard across the United States now, which is you have what are called monofocal implants, which that's just the distance only. You have toric implants, that's correcting again for distance typically and correcting that astigmatism. And then you have multifocal implants. There are also extended depth of focus implants There's some newer ones, light adjustable lenses that are kind of being worked through as well. But the main ones are, again, deciding what your primary goals of the correction are. And, as with anything, technology has some limitations. So we discuss that, what a specific patient's needs are, and try to correct that for that specific person. So, but have great results, and always happy. It's part of the job that's very gratifying, is to restore someone's vision, and also many times, or most of the time, get rid of their distance correction at a minimum, and help them out.
It's life-changing for a lot of people, isn't
It
it?
is. It is. The biggest thing, too, people don't think about, as you get older, you reduce your risk of falls, which can lead to bigger medical problems, hip replacements, knee replacements, things like that are much more dangerous. I don't say dangerous, but just a surgery that has more potential complications, So if we can prevent many things by a simple 10 or 15-minute cataract surgery, that's awesome, So
When you said that, I was thinking about my dear mother, who was an immaculate housekeeper. She had cataract surgery, and we took her home. The next day, she said, "How come you didn't tell me my house was so dirty?"
Exactly.
Which it really wasn't. But I mean, to her, she could see well again. And
right. I've had that story many times. So it's very rewarding, though, to have people be able to function in life much more significantly. The other big thing is many people are in jeopardy of losing their license to drive, and so restores that ability again. And we all, just like when we were 16, like that freedom, and love to be able to just get in our car and go along. And after you do it for 40 or 50 or 60 years, and then you can't anymore, it's a pretty big deal.
Yeah, I can understand. Macular degeneration, would you talk about that a little bit, Dr.
Again,
Bull?
that's, again, more of an age-related condition. We typically see that in people 55 or older. Again, not everyone has that problem, but there can be, family members that have it, so it might be more common. One of the biggest risk factors is smoking, so eliminating that is always very helpful in helping to prevent that. But it's just a degenerative process in the central part of your retina where we see 20/20. That's where our highest concentration of cone receptors are, which is most of your listeners probably should remember old TVs that had RGB cathode ray tubes in it, so it's red, green, and blue.
Oh, yeah.
And so that's what your cones are. They give you that really acute 20/20 type vision, and that's the highest concentrations in your central macula. And so we want to try and preserve that. There are conditions, there's basically two types of macular degeneration. It's the same condition. It's just whether bleeding or swelling develops or not. So we kind of label it as dry and wet. So wet means there's been some bleeding through one of the layers underneath the retina, and then that can cause dysfunction of those central retinal cells and cause problems with your central vision, which is very disabling. So if the wet type occurs, then that's when we do intervene with injections into the eye. Not everybody's happy to hear that, but it's when I was a resident, we didn't have that available, and that technology has become, or treatment has become, more readily available now. I refer that to retina specialists, usually at the University of Wisconsin or Gunderson or SSM, because they are they do lots and lots of those. So, but that's a treatment that's helpful, but we certainly do have diagnostic equipment to, actually visualize whether that's going on in addition to examination, and also monitor, dry macular degeneration over time as well.
Dr. Bull is our guest on the morning show, and again, available for appointments at the Richland Hospital. Glad to pick your brain a little bit here. You mentioned eyelid issues.
Mm-hmm.
Maybe you could talk a little bit more about those.
So we do, there's several things that people can have. The most common things would be entropion, which is a inward turn of the eyelid, where the lashes rub against your cornea, so very irritating. Can eventually lead to damage to your cornea if left untreated. Ectropion is the opposite. The outward the lids turn outward, and so there's air exposure, and so people get red eye again, dryness of the cornea. So those things really need to be fixed. Generally, it's about a 15-20 minute procedure if it's just on one side, where we tuck the eyelid typically out laterally and tighten it up that way, but there are other ways to also do that. Other conditions, people have excessive eyelid skin, and it causes hooding and limitation of their peripheral vision, especially superiorly, and that can consequently, limit your vision and your ability. It's a fine line between cosmetic and not cosmetic. So, but we've done a few, since I've been here, of blepharoplasty is what that's called. So we're just taking an amount of skin off of there to eliminate that, so it's not in the way any longer. Another condition is ptosis, which is a droopiness of the lid, and there's a tendon in your lid that sometimes gets loose, and that has to be tightened back up, and so that can be corrected to help raise the lid higher again, or where its normal position is.
So those kind of surgeries would be just kind of inpatient, outpatient the same day then, right?
They're just outpatient surgeries, yeah. You go home the same day.
Yeah. What about dry eye syndrome? I mean, sometimes our eyes are dry. Is that something that we should be concerned with?
Very common. See that especially in postmenopausal women. Changes in hormones a lot of times will contribute to it, but also allergens, everyone's experienced hay fever type things, different times of the year, and the eyes are gritty, sandy feeling. All those things can be treated. There's a lot of different therapies out there now. Obviously, the most common thing to start out with is supplementation with artificial tears, but you can also, help with lid scrubs and warm compresses sometimes help, and omega-3 supplementation, fish oil supplementation oftentimes can be of benefit. There's other treatments out there, such as putting little plugs in the tear ducts to keep more tears on the surface. There's some light therapies and other things on the eyelids that can be done. There's quite a few things that are out there, but all trying to relieve that irritation that's very chronic and bothersome for patients most of the time on a daily basis.
Watching a sad movie, that might work too, right?
Yeah, a little bit. Briefly.
Briefly, right, exactly. Temporarily. What about eye exams for patients with diabetes? I think you alluded to that a little bit, but could you talk a little bit more about that?
Right, just looking at the back of the eye and also imaging it if we feel like there's something going on helps us to monitor if there's progression over time or if there's anything at all to begin with. But with diabetes, blood vessels, smaller blood vessels in the eye can become leaky. I always tell patients it's like having a PVC pipe versus having a French drain. You've got little holes that develop in the junctions of the inner lining of the blood vessels that can cause leakage, and that can go into the space of the retina where the nerve cells are. Nerve cells don't like hemorrhages or swelling around them. They don't function well. It's just like if you have some swelling in your ankle after you twist your ankle, and you might have some tingling in your toes. Well, that's because the nerves are kind of compressed and can cause that, or carpal tunnel's another good example. So in your eye, that just means you're going to have blurred vision or problems that are caused by that swelling or hemorrhage in that area that can potentially cause damage to the nerves, and that could be permanent. So our goal in screening people is to pick up those things early. If there is something, I've had people that were 20/20 when they walk in the door, but there's something that was very close to kind of a critical area, that central macula again. And nowadays, most people, again, get injections, but when I was training people, got laser treatments that can also, it's still used on occasion, but picking up those things so that you don't have a loss of vision. By the time you have loss of vision with diabetes, many times our goal then is to prevent further vision loss. That's very a common thing I stress to patients that have that going on, because the damage has been done. We're putting up those sandbags in the flood and preventing further damage from the floodwaters, right? And then obviously you want to control your blood glucose levels systemically, so that helps in guiding your primary care physician and in giving you the most appropriate treatments and helping to maybe get that blood sugar a little bit lower than what it has been, potentially. So.
In your time of practicing, Dr. Bull, I'm guessing technology has just grown so fast, but how has technology changed eye care maybe in that time?
From my standpoint, I think the imaging is dramatically improved. I mean, we have something called OCT imaging, which is optical coherence tomography, which gives us almost a cross-sectional analysis of the retina, and it just helps to show things so much more dramatically than just me looking with lenses and through a microscope and trying to figure out what's going on sometimes. So it helps to really hone in on what the actual diagnosis is. Also in glaucoma, that same technology, OCT, we can measure the nerve, and in many instances we're measuring at least 1,100 different spots in the thickness of the nerve cell layer. And again, in glaucoma, what happens is there's a loss of nerve cells and damage to them. So the thickness is going to decrease. So we can, over time, monitor that. And then if we're intervening with drops to prevent that from happening, then we can say, yeah, this is stable. And just as opposed to just, oh, it looks about the same. Okay. So it's not just about, a lot of times patients think it's just about eye pressure. And that's a risk factor, but that's not the only factor. So we have to use these other diagnostic tools. That's why we may see somebody 2 or 3 times a year that has actual glaucoma, or somebody that might be suspicious for glaucoma. So, and so we want to watch that and monitor it closely.
What can we expect from a visit if we go to see you, Dr. Bull?
Basically, I provide comprehensive exams. I will explain things as I'm doing now very significantly. That was part of moving to an area where I can take the time and explain things to people. It's always more helpful both for myself but also for the patient to know, hey, this is what's exactly going on. I try to explain things in just a common style and not use a lot of medical lingo, just because it's more impactful, and if you understand what's going on, you're more likely to do the treatment to help prevent it from happening and understand why it's important.
You've worked all over the country. Are there things that are common here in Wisconsin that may not be in California in terms of dealing with eyes and eye care?
Not too much. I mean, many times we'll see, I think down in the southern states, I saw probably more of some corneal conditions called pterygium, where it's a growth on the cornea. That's just common with UV exposure. So we don't always get a lot of UV exposure here.
No, not as much.
But other than that, most things are very common across. There are some conditions that we see in more in Nordic ancestry, such as a condition called pseudoexfoliation. I worked with a mentor of mine. She was an ophthalmic pathologist, and she is one of the world's experts in that condition. And it's just, it's kind of, we call it a pseudo glassblower's disease. It's the surface of that lens, that capsule, can get this little appearance. We call it dandruff. Sometimes it looks like it, or it might have rubbed off spots, and that can cause a type of glaucoma. So that's not uncommon. It's not like absolute that because you have that heritage that you might get that, but it's just a thing that always I'm looking for as well, and pretty much anybody. But it can also impact when we do cataract surgery. It can cause the support structure to be more brittle around that, but we have ways to get around that as well and not have a problem with the surgery as well.
What about the fact that so many of us stare at computer screens all the time now? There's a lot more eye strain than there used to be.
Yeah, again, most of that, I mean, a lot of the blue wave energy, there's a lot of blue blocking glasses out there that are helpful. I would say most people, what they experience most of the time is just dry eyes, because you're, number one, when you're staring at something for a while, you don't blink as often. So that can do that, but also just that air exposure across your eye and just not taking a break. Most of the time to my patients, I'll say, at least every 15 minutes, take a break, look at a distant target. It kind of relaxes your eyes as well. People will get headaches because they're kind of zooming in that area, and especially if you get past about 45, then it gets a little bit more difficult to do that zooming anymore. So
and as far as that goes with eyes and that kind of thing, do you cause damage if you maybe don't have the right prescription, or you're trying to get along with what I call cheaters? I mean, can you cause more damage or not?
Not typically. Most people, if they have the wrong prescription, the thing most people get, eye strain or headaches right behind your eyes or around your eyes. And so, it's preferable not to do that. Just your overall health and being able to see will be much better, if you have the right prescription in front of you. But again, the biggest thing would be just, dry eyes, things like that. But it's at that point, if there is blurred vision, that's something you always want to get checked, because may be something more serious, or maybe as simple as just having a prescription that needs to be changed, or a new one that's developed.
We talked about it a little bit at the outset, but I know you're excited to meet patients and meet folks here in the Richland Center area.
Yes, we are starting Friday. Already have some patients scheduled, so as we proceed along, we'll start to schedule surgeries. And typically, if someone comes in for a cataract surgery, we'll evaluate, and then we usually have to bring them back to in order to do some testing. So we have to know the length and curvature of your eye and some other measurements that are included with that, and that's how we calculate what implant is correct for you. So it's stylized for you as opposed to somebody else. And so that specific implant then is ordered, and that's what we put in at the time of surgery.
Anything else you'd like to leave us with today, Dr.
I'm
Bolt?
just excited to be here and provide this service. I hope it's helpful to the community so that people can access care closer to home.
Good. Well, welcome to the community. Glad to meet you.
Nice to meet you. Thank you.
Dr. Douglas Bull joining us. For more information, you can contact the Richland Hospital. They can make appointments.
Correct.
Right there.
Yes.
Just call the clinic and get it done then. So,
all right.
We'll have more coming up on the morning show. Thanks for joining us.